We'll talk about the phases of migraine today. You see a picture of the beautiful Sonoran Desert there and a picture of the Mayo Clinic Hospital, which is where I work. And when you think about the phases of migraine, you can really think about the phases of the moon. If you condensed a 30-day lunar cycle into a 3 or 4-day period, if the full moon is the headache, there's a lot that happens in the brain and for you as a patient before the headache and after the headache, in the vast majority of people. And I think we've done everyone a disservice by just focusing on the headache, because migraine has become synonymous, if you will, with headache. And it's so much more than just a headache. And really, headache is what's driven drug development in this field for a very long time. But I think that's going to change, which makes this talk, a very timely one. So although I'm in Arizona, I'm actually a neighbor of yours. So I've got it up in the upper left-hand corner there, you'll see Ireland, and you'll see where my home is, which is in Cape Breton, Nova Scotia, which is where I was raised. That's my home. And in fact, on the right-hand side, you can see a place that I used to go to a lot. It was just a drive up the road from me in Cape Breton Island, a place called Irish Cove. So there's a lot of Irish in Nova Scotia and a lot of Irish in Cape Breton. So I'm one of you, I suppose we could say, or close enough. So migraine is an inherited neurological disorder. When I say inherited, I mean it's a polygenic disorder. There is one type of migraine that's a typical, what we call autosomal dominant genetic disorder that's passed down through families, but mostly migraine's a polygenetic disorder, which means that there are probably hundreds of genes that increase the risk of one developing migraine. We've identified a lot of them, over 40 of them so far. So it is an inherited neurological condition that runs in families, and it's characterized by, of course, headache, but it's characterized by a lot more than that. Neurological symptoms, affective mood symptoms, sensory symptoms, circadian symptoms, disruption in sleep, autonomic symptoms, changes in heart rate, blood pressure, gut motility, vestibular system symptoms, cognitive symptoms, gastrointestinal symptoms. So migraine is a very complex brain disorder, one of the most complex brain disorders actually, and there's nary a place in the brain that's spared during a migraine attack, as I'm going to show you. And for every one of those categories, and for every one of the symptoms that an individual with migraine has, there is an anatomical and a biochemical signature that's coming from a place in the brain, and there's a mechanism that underlies that symptom, even if we're not smart enough to figure it out just yet. So we're here to talk about the phases of a migraine attack. And as I said, it's central that we'll talk about headache. But as I mentioned when I talked about the moon, there are things that happen before a full moon and after a full moon, before a headache and after a headache. So we've divided this up classically into 4 phases, but I'm going to add one called the interictal phase. So there's a prodrome that comes before the headache. There's sometimes people will experience an aura, maybe in up to a third of people, headache. Then there's a postdrome that can last up to 48 hours. And then there's an interictal phase, which means that in between attacks, some people will still have symptoms of migraine, even if they don't have head pain. And that can occur in 30%. So you see that the prodrome can last up to 2 days. The aura can last about an hour or a half an hour. The headache itself can last up to 3 days. The postdrome can last up to 2 days. And then there's the interictal period. So a migraine attack, if you will, is much more than just a headache, and it can last several days. And I'll talk about some of the treatment implications for that near the end of my presentation. So activation, as I said, there's a chemical and an anatomical signature for every symptom that a person has. So activation of different brain regions contributes to different migraine-related symptoms. So in the prodromal phase, one can see symptoms such as fatigue or food cravings or thirst or nausea or brain fog or cognitive disturbance. People just can't concentrate or focus. Neck discomfort maybe, or heightened sensitivity to sound, to light, to odors. And sometimes those symptoms of the prodrome get mixed up with triggers of the attack. So if you didn't have a good night's sleep last night, or you had a craving for a certain food, or you were perhaps a little more anxious than usual, you'll think that, well, maybe I was just stressed out, anxious, and maybe that triggered my attack, or maybe I didn't sleep well last night, and maybe that triggered the attack, or maybe that chocolate I ate, or that whatever I drank that I had a craving for, that triggered my attack, when it actually could be the beginning of the attack itself. Well, let's talk a little bit about the prodrome first. So the holy grail of discovery research in migraine was really in part finding out where migraine begins in the brain. And we think we have a pretty clear idea of where migraine begins in the brain. And it seems to begin in an area of the brain called the hypothalamus. And so this is a cutaway view of the brain, as if you carve someone down the middle and you're looking in at half the brain, and you can see where the hypothalamus is located. It's kind of right in the center of the brain. And what is the hypothalamus responsible for? Well, it's responsible for pain. It's responsible for controlling the sleep-wake cycle, for feeding, hunger, satiety, when you get full, when you feel hunger, thirst, arousal, when you feel fatigued or when you feel very energetic, and what we call autonomic and endocrine regulation. So it controls hormones in the body, and it controls the autonomic nervous system. Autonomic, I sometimes tell patients, it's like the automatic nervous system. It's the things that you don't think about, like your gut moving or breathing or your heart rate or your blood pressure. It's things that really you don't concentrate on, you don't focus on, but they're automatically controlled. So, the hypothalamus controls a lot of different bodily functions. And so it should be no surprise that during the migraine attack, a lot of those bodily functions are affected. And studies have shown now that activation in the hypothalamus occurs prior to the onset of headache. So headache is not the first symptom of an attack in at least 3/4 of people. And I'm showing you imaging study from a recent paper that was published. And this is an MRI scan showing activation in the center of the brain, right in the hypothalamus in a group of patients. So we believe that the hypothalamus now is the first site to be activated during a migraine attack. That's this picture blown up here, so you can see the hypothalamus here. But how does the hypothalamus that may be driving that prodromal phase, how does that link up with the headache? Because we know that headache often follows the prodromal phase. Well, there's a part here in the brainstem. So the hypothalamus is up here and the brainstem is here. And there's a part here called the trigeminal nucleus caudalis. Just call it the trigeminal nucleus. And the trigeminal nucleus, out of that trigeminal nucleus come three nerves, three different trigeminal nerves. And this first branch of the trigeminal nerve basically supplies everything inside of the head that can cause pain. So blood vessels and the capsule over the brain. The brain itself is not pain sensitive. So you can cut the brain and you wouldn't feel it. But if you cut the covering of the brain to get into the brain, that's extremely pain sensitive. And of course, the blood vessels are pain sensitive. So that first division of the trigeminal nerve supplies everything that's pain sensitive. And that's how pain gets into the brain. But how does the hypothalamus link up with the trigeminal nucleus? I kind of liken it to a brake and an accelerator. So what studies have shown is that in the run-up to the migraine attack or a headache, we see increasing activation in the trigeminal nucleus. So the trigeminal nucleus starts to become hot, right? And starts to burn even before you have head pain. And that activation, or that the extent to which it's burning, increases right up to the time of the actual attack. So something's going on to drive that trigeminal nucleus before you even experience pain. And it looks like it's coming from the hypothalamus, because the hypothalamus sends descending pathways and nerve fibers down to the hypothalamus. So I put here, just the way to think about this is if the hypothalamus was up here and it was generating the lightning, right? When the lightning strikes the ground, it starts a fire. So it looks like the hypothalamus is either the brake or the gas pedal, or perhaps at times both. maybe a lot of the time it's regulating the brake, so that the brake is typically on for many people with migraine. They don't always have head pain, at least some people don't. And I'm sitting here without head pain today, even though there's traffic coming in along my trigeminal nerves, I'm not feeling it as pain. But when that brake is lifted and the accelerator is pressed, you can light a fire in this trigeminal nucleus. And now that normal traffic coming into the brain is now experienced as a headache. So that's how the prodrome probably leads to the headache. Let's talk a little bit about the aura now. So the aura, and some of you may have aura, it happens in about 30% of people, but it doesn't necessarily have to happen all the time. Some people have aura with every single migraine attack. Some people might have just a couple of auras in their entire life, and then there's everybody in between. So, but aura, we think, is due to what we call cortical spreading depression. It was shown in rabbits and other animals back in the early 1900s. So when you drop a little potassium on the surface of the brain, or when you stick a needle in the surface of the brain of an animal, it triggers this slow wave of what we call cortical spreading depression. Think of it like throwing a rock in a pond and watching that ripple go across the pond. But it's an electrical activity, and it's neurons and glial cells, the two most abundant cells in the brain, being activated electrically. But unlike a seizure, which is the kind of the same thing that spreads quickly across the brain, cortical spreading depression of the migraine aura spreads gradually, about 3 millimeters per minute. So it's very slow moving, which is why for those of you who might have aura, you might see a little dot or a little sparkle, and then it starts to grow and expand and then contract and go away. So that's the typical hallmark of the aura. It tends to evolve over 5 to 20 minutes and then resolve within an hour after it peters out and dies out. And you can see that here. If you record with an EKG, you can see a heightened activity here, a lot of electrical activity followed by suppression of activity. Because once the brain electrically discharges, it's spent. It can't be activated anymore. And so what typically we see is, because what we call depolarization, or when it electrically discharges, that takes a lot of energy. And if it takes a lot of energy, it creates a lot of blood flow. We need more blood flow to bring more nutrients to the brain to drive that energy. So we see about a 300% increase in blood flow at the onset of the aura when everything's electrically discharging. And then when everything is spent, we see a reduction in blood flow. Not because blood vessels go into spasm, but because the brain is no longer electrically able to be activated. It's done. It's hibernating, and so it doesn't need all that blood flow. So we see this spreading wave of electrical activity followed by a spreading wave of increased and then decreased blood flow. And what do you see as a patient, or what do you experience as a patient? Well, you may experience a visual aura. 90% of the time, the aura is visual. And so you may see a blind spot in your vision, or you may see a colored sort of scintillation, we call it, that happens in the vision that can spread and contract over time. It may be numbness or tingling, most commonly in the hand, in the arm, around the mouth, in the tongue. And so we call that chiaro-oral. Chiro meaning hand, oral meaning mouth. And typically, unlike a patient who's having a stroke, who will feel numbness in their face and hand and arm and leg all at once, that's not what happens here, because remember, it travels slowly. So sometimes people will notice numbness or tingling around the corner of the mouth, then it goes inside the mouth, and then in the tongue, and then it may involve the fingertips, and then it marches up the arm. That's not the way a stroke behaves. That's the way migraine behaves. Sometimes it involves language. So people can't express themselves, or they can't necessarily understand what people are saying. Mostly it's expressive. So you can't find words, and you can't quite express yourself the way you normally would. Sometimes it's other symptoms like vertigo or double vision, depending on where it is in the brain. And then if you have hemiplegic migraine, it can be paralysis on one side of the body. But remember, this spreading electrical event, depending on where it is in the brain, that will determine what symptoms you have. So 90% of the time, it's in an area called the occipital lobe. So you're going to experience a visual aura. But if it spreads or begins in the parietal lobe, you're going to experience numbness or tingling. If it involves the language areas in the brain and the temporal lobe, well, you're going to have problems with language. If it involves the motor areas of the brain, you're going to go paralyzed on one side. So really, where this electrical event is happening in the brain will determine what symptoms you experience. But remember, if you have a symptom, don't let anybody tell you it's not real, because again, there's an anatomical and a biochemical and an electrical signature for that. And we've been able to now view this in the human brain. So this is an example of 3 patients whose brains have been flattened for purposes of illustration, but you can see this is the activity and blood flow over here, and the big increase here is then followed by a decrease, right? Exactly what we see in the animals. And then we see in the humans this propagating from the tip over here over the occipital lobe at a rate of about 3 millimeters per minute. And so you can see this march across the brain, right? This electrical and this blood flow march. And that's why you get a march in your vision, or you get a march up one side of the body, right? So we think that this electrical event in the brain is responsible for the aura. Now let's talk about the headache. The headache, again, I'll come back to this trigeminal nerve. This is the trigeminal nucleus. You remember we talked about that, and this is the first division of the trigeminal nerve. And here it goes, and it goes out here, and it connects with the blood vessel, and it connects with this capsule over the brain called the dura, the meninges over the brain. And when this nerve discharges, becomes activated, it releases all kinds of things. But one of the things that it releases is CGRP. And a lot of the new drugs that have become available over the past 2 years, what do they target? CGRP. Because CGRP dilates blood vessels. It causes mast cells, which is a type of cell in the covering of the brain that, when discharged, releases all kinds of things that cause inflammation, like histamine, for example. And when CGRP is released, so it does these things out here, and then it also activates the nerve fibers and sends increasing traffic into the brain. And remember, this is a pain nerve. So when it's activated, it releases CGRP. CGRP does its things. It reactivates the nerve. So it's this vicious cycle that's created, where the more active the nerve is, the more it releases CGRP, the more active the nerve is, and the more traffic that's coming in. It's like rush hour in Dublin compared to 2 a.m. in Dublin, right? In Dublin, a lot of traffic, right? And downtown is very busy. You can think about the traffic coming in to the brain like noon hour in Dublin. I was in Dublin a year and a half ago. It doesn't really get that busy, not like Phoenix, but it gets busy enough. And so when the traffic comes into the trigeminal nucleus, signals are then sent up to the surface of the brain, up here, and then it's registered as pain. That's the highway, that's the pain highway, if you will. And so that's really the anatomy and the physiology of headache. And that's what drove and continues to drive drug development. And you'll note here that I have something called PACAP 38. Guess what? CGRP is not the only thing released. PACAP is also released. And now there are drugs in development that are targeting that as well. So it's naive to think we're going to boil migraine down to just one protein or one neuropeptide, CGRP. CGRP works in some people, but it doesn't work in everybody when you target it. And that's why it's important to come up with other drugs that target other proteins or neuropeptides that are released by the trigeminal nerve. And so here's another illustration of the hypothalamus. You remember, it's the brake or the accelerator having an influence on the trigeminal nucleus. Here's the trigeminal nerve coming out here that supplies the blood vessels and the meninges. And in the trigeminal nerve, we have 2 different types of nerve fibers, a C fiber and an A fiber. I only bring that up because in a pain nerve, there's 2 different types of fibers running through. It's kind of like a wire, right? If you strip the insulation off a wire, you got all these wires. Well, there are 2 different types of wires, or 2 different types of nerves, a C nerve and an A nerve. The C nerve is the nerve that releases CGRP. The A nerve contains the receptor for CGRP. Because any protein has to have a receptor to bind to. It's kind of like a key in a lock, right? A key is no good to you unless you have a lock that you can open the door. And so the drugs that have been developed for migraine either target CGRP, indicated here by these cherry red circles, or they target the receptor for CGRP, and therefore block the signaling of pain along the nerve. That's how they work. So now you understand a little bit about the anatomy of the trigeminal nerve, why CGRP is important, and why it's become such a focus of research and drug development in the field. Let's talk a little bit about the postdrome. The postdrome is what occurs after the headache. And the postdrome looks kind of like the prodrome, where you have sensitivity to light or sound, nausea, fatigue, you're just washed out, you're hungover, you still perhaps have a cognitive fog, you're not sort of firing on all cylinders, you may still have some neck discomfort. And one of the things that's interesting is that because a lot of the symptoms seem similar between the postdrome and the prodrome, the symptoms of the postdrome may be just leftover or hungover symptoms that had begun in the prodrome, because the same brain pathways and networks seem to be activated in both. But make no mistake, there's a substantial change in blood flow and brain activity in the postdrome. And here it is. So here is a series of patients who had a migraine headache. They got sumatriptan. They took sumatriptan. Their pain went away. But look at their brain after the pain went away. What I'm showing you here is a PET scan showing everything in blue shows reduced blood flow. So you can see how diffuse, right? The reduction in blood flow is all over the brain, even after the pain has resolved. Now, it won't surprise you to think that with this kind of change in the brain, you're not going to feel normal. You're not going to feel right. And recently a study was done, this was an MRI study, but basically reproduced what this study back in 2008 showed, which is a significant reduction in blood flow, both at the surface of the brain as well as deeper in the brain. This is a phase of migraine, this postdrome, that hasn't been nearly as well studied as certainly the headache and even as much as the prodrome. But you can be sure that we're going to be focusing on this in the years to come to find out exactly how to shut this phase off. Because we've been focused on how to shut the headache phase off. But if we could shut the prodrome phase off, we wouldn't have the rest of the phases, right? And if we can shut the postdrome phase off, then we can save people up to a day or two of disability after the headache is over. So it's important to understand the biology of each of these phases so that we can learn how to shut each of them off. And then finally, there's this, and by the way, the postdrome, recent studies have shown that it occurs in both 80 to 95% of people. So it's not usual that a person will have their headache end and then they'll feel back to normal, ready to go, right? For those of you who have migraine attacks, that just doesn't happen most of the time. Some people only have an hour or two where they're hungover. Some people have up to 2 days where they're hungover. But it occurs in the majority of people. Now, the interictal phase is one phase that really interests me, because I have family members and I have friends and I have patients who tell me they never really feel quite normal even in between their attacks. Or it's not that they necessarily feel abnormal, but they think that their sensitivity to light and to sound, they can never have the radio too loud, or they can never be really out in the sun or in bright light, just because they're less tolerant of it. And they think that's normal, but it's not. All right, this is the way their brain processes that information coming into the brain. So up to a third of patients have these symptoms in between attacks, and it may be even more than that. I just don't think people recognize the fact that when they're having trouble focusing and concentrating today, and they can't figure out why, because they had a good night's sleep last night, maybe they're in this interictal phase. Maybe it's their brain not functioning normally, but they're not having a headache, so they don't recognize it as a migraine symptom. And we know that there are structural and functional changes in the brain even in between attacks. So the more frequent someone has attacks, some people have 2 attacks a month or 1 attack every other month. Some people have attacks every single day or they're never without symptoms. And then there's everybody in between. But the more frequent your attacks, the more likely it is we're actually going to see areas of the brain get thicker. And what I'm showing you here is a study that showed this is the sensory or pain area of the cortex of the brain. And this group of investigators showed that that area of the brain becomes thicker. It's being bombarded so often that it just actually becomes thicker. More cells. It's almost like me doing arm curls, trying to get my bicep larger. The more curls I do, the larger my bicep is going to become. So the more you bombard that area of the brain, the larger it can become. So it structurally changes, but it also functionally changes. So if I showed someone with migraine, who, by the way, isn't having any symptoms, a visual stimulus, a checkerboard or a light, here are the areas of the brain in orange that light up in a migraine in someone whose brain has migraine compared to someone who's never had migraine. So this is the way a person with migraine, this is the way they process a visual stimulus coming into their brain in a way that someone who doesn't have migraine never would. So that's the reason why a lot of people with migraine, or some people with migraine, never like light. They never like bright light, and they never like complex visual imagery. Same thing if it's pain. If you apply the same painful stimulus to someone with migraine compared to someone who doesn't have migraine, look at the areas of the brain in orange that are activated in someone who has migraine that isn't activated in someone who doesn't have migraine. The take-home message here is that the brain of someone who has migraine processes information coming into it in a way that's very different than the person who doesn't have migraine. And this could be a smell, it could be a sound, it could be any sensory stimulus coming in to the brain. Migraine brain processes it differently. So in the last couple of slides here, what does this all mean for the patient? What it means for the patient is that, number one, remember I said, if we could stop it at an early phase, the rest of the phases might not happen. Well, we've known this for years, that when people treat their headache, when it's mild, it gets better a lot quicker and they feel a lot better than when they treat it when the pain is already moderate or when the pain is severe. In other words, the earlier you treat your pain, the better off typically you'll be. And it doesn't matter whether you're using an over-the-counter drug or whether you're using a prescription medication. The problem is that if you allow the pain to progress to a moderate to severe intensity, what happens is the brain develops what we call sensitization. And the brain doesn't like to be sensitized. Because when it's sensitized, it's kind of like putting a match and lighting a fire. Sometimes it takes a long time for that fire to go out, and sometimes that fire never goes out. So the longer the brain and the more often the brain is sensitized, the more likely it is that that person's going to get worse over time. Their attacks are going to be longer. They're going to be more frequent until they become like patients I see where they never have a waking moment that's pain-free. So the brain doesn't like to be sensitized like that. So shutting things down early is really important. The problem is that 50 to 60% of people, their pain peaks within 30 to 60 minutes. So sometimes they don't even have time to get to a medicine. And then 50% of attacks of migraine occur when they wake from sleep or they're awakened from sleep. And so it's already moderate or severe by the time they treat it. So even though we have the best of intentions and we tell our patients, look, treat while the pain is early, some people can do it, but some people can't. And some people can't do it for all of their attacks, certainly. And so what if we could actually treat even earlier, like during the aura or during the prodrome phase? Is that a possibility? Well, yeah, it's a possibility, especially with some of these newer drugs. One of the problems has been that taking a triptan, for example, during the prodrome, most people wouldn't do that, A, because you don't get that many, and B, because if you get it wrong and you're feeling a little fatigued today and you can't concentrate and you think you might have a prodrome, you don't want to overuse the medication or use it when it's not necessary, because triptans, like all other acute drugs, can cause overuse headache or rebound. But now some of the new treatments that are coming out that we use for treating an attack don't produce overuse headache. In fact, the more often you use them, the less frequent your attacks can become. So we're finally got new therapies coming out where it tees up the possibility of treating during the prodrome. And I think in the future, you're going to see studies, acute migraine studies, move away from treating headache and move towards treating the prodrome to see if we can even prevent the headache and all the other phases from occurring. And finally, what does it mean in terms of prevention or preventive treatment? Well, let's say, for example, this was a patient who comes to see me and I ask them, they bring their diary in and they show me they've had 4 migraine headaches. How many migraine headaches have you had last month? I've had 4. Here's my diary. Am I going to start that patient on a preventive treatment? Maybe, maybe not. It really depends. But this isn't a person who you would immediately jump to starting on prevention. We in this field, and I'm talking about me too, for the past 25 years, 30 years, we count headaches. That's what we count. That's what patients count. That's what we tell them to count. And that's what drives clinical drug development. Every migraine prevention trial we do, what is the primary endpoint? The single thing we're looking for is to reduce the number of headache days. But what if I ask this person to tell me to count the prodrome, to count the postdrome, and to count days when they have migraine symptoms? And now what if it looks like this? Now we're looking at migraine symptom days, not just migraine headache days. And if this is the number of migraine symptom days, well, now I'm thinking, now I probably will start a preventive treatment, because what I don't want is I don't want this calendar to turn yellow and red. I certainly don't want it to turn red, where their patients are having a headache every day. So just like I think there's an opportunity now to start intervening earlier during the course of an attack in one of these early phases, I think there's an opportunity to intervene earlier when patients are younger, before they get into trouble over time, by counting the number of migraine symptom days they have. Because remember the phases, right? Your brain is still in a migraine attack, even though you don't have a headache. So I think we ought to be thinking really dramatically different than we're currently thinking when it comes to selecting the patients that we're going to put on preventive treatment.